Hey everyone, this is your Nandini ma'am, and I'm going to continue with the audio reading of Human Anatomy, Volume 1, Upper Limb and Thorax, and we'll start chapter number 2, Bones. So let's get started. Introduction. Out of 206 total bones in man, the upper limbs contain as many as 64 bones. Each side consists of 32 bones, the distribution of which is shown in Table 1.2 and Figure 1.1. See Chapter 1. Since bones of the two upper limbs are similar, one needs to learn only 32 bones out of a total of 64 bones. This applies to soft parts as well. One learns only one upper limb, the other upper limb gets learned on its own. This is true for the whole body except parts of abdomen. Actually, one needs to master only 50% of the body and other 50% gets mastered itself. The individual bones of the upper limb will be described one by one. Their features and attachments should be read with the bones before undertaking the dissection of the part concerned. The paragraphs on attachments should be revised when the dissection of a particular region has been completed. Clavicle. The clavicle, Latin a small key, is a long bone. It supports the shoulder so that the arm can swing clearly away from the trunk. The clavicle transmits the weight of the limb to the sternum. The bone has a curved part called the shaft and the two ends lateral and medial. Side determination. The side to which a clavicle belongs can be determined from the following characters. Number 1. The lateral end is flat and the medial end is large and quadrilateral. Number 2. The shaft is slightly curved so that it is convex forwards in its medial 2/3 and concave forwards in its lateral 1/3. The inferior surface is grooved longitudinally in its middle 1/3. Peculiarities of the clavicle. Number 1. It is the only long bone that lies horizontally. Number 2. It is subcutaneous throughout. Number 3. It is the first bone to start ossifying. Number 4. It is the only long bone which ossifies in membrane. Number 5. It is the only long bone which has two primary centers of ossification. Number 6. There is no medullary cavity. Number 7. It is occasionally pierced by the middle supraclavicular nerve. It receives weight of upper limb via lateral 1/3 through coracoclavicular ligament and transmits weight of upper limb to the axial skeleton via medial 2/3 part. See flowchart 1.1. Features. Shaft. The shaft, figures 2.1a and b, is divisible into the lateral 1/3 and the medial 2/3. The lateral 1/3 of the shaft is flattened from above downwards. It has two borders, anterior and posterior. The anterior border is concave forwards. The posterior border is convex backwards. This part of the bone has two surfaces, superior and inferior. The superior surface is subcutaneous and the inferior surface presents an elevation called the conoid, tubercle, and a ridge called the trapezoid ridge. The medial 2/3 of the shaft is rounded and is said to have four surfaces. The anterior surface is convex forwards, the posterior surface is smooth, the superior surface is rough in its medial part, the inferior surface has a rough oval impression at the medial end. The lateral half of this surface has a longitudinal subclavian groove. The nutrient foramen lies at the lateral end of the groove. Lateral and medial ends. Number 1. The lateral or acromial end is flattened from above downwards. It bears a facet that articulates with the acromion process of the scapula to form the acromioclavicular joint. Number 2. The medial or sternal end is quadrangular and articulates with the clavicular notch of the manubrium sterni to form the sternoclavicular joint. The articular surface extends to the inferior aspect for articulation with the first costal cartilage. Attachments. Number 1. At the lateral end, the margin of the articular surface for its acromioclavicular joint gives attachment to the joint capsule. At the medial end, the margin of the articular surface for the sternum gives attachment to fibrous capsule of sternoclavicular joint all around, figures 2.2a and b. Articular disc posterior superiorly, interclavicular ligament superiorly. Third, lateral 1/3 of shaft. The interior border gives origin to the deltoid muscle, figure 2.28. B. The posterior border provides insertion to the trapezius muscle. The conoid tubercle and the trapezoid ridge give attachment to the conoid and trapezoid parts of the coracoclavicular ligament, figure 2.2b. Fourth, medial 2/3 of the shaft. Most of the interior surface gives origin to the pectoralis major, figures 2.2a and b. Half of the rough superior surfaces gives origin to the clavicular head of the sternocleidomastoid. The oval impression on the inferior surface at the medial end gives attachment to the costoclavicular ligament. The subclavian groove gives insertion to the subclavius muscle. The margins of the groove give attachment to the clavipectoral fascia. The posterior surface close to medial end gives origin to sternohyoid muscle. The subclavian vessels and divisions of trunks of brachial plexus pass towards the axilla lying between the inferior surface of the clavicle and upper surface of first rib. Subclavius muscle acts as a cushion. The nutrient foramen transmits a branch of the suprascapular artery. Ossification. The clavicle is the first bone in the body to ossify. Except for its medial end, it ossifies in membrane. It ossifies from two primary centers and one secondary center. The two primary centers appear in the shaft between the 5th and 6th weeks of intrauterine life and fuse about the 45th day. The secondary center for the medial end appears during 15 to 17 years and fuses with the shaft during 21 to 22 years. Occasionally, there may be a secondary center for the acromial end. Clinical anatomy. The clavicle is commonly fractured by falling on the outstretched hand, indirect violence. The most common site of fracture is the junction between the two curvatures of the bone, which is the weakest point. The lateral fragment is displaced downwards by the weight of the limb as trapezius muscle alone is unable to support the weight of upper limb, figure 2.4. The clavicles may be congenitally absent or imperfectly developed in a disease called cladocranial dysostosis. In this condition, the shoulders droop and can be approximated anteriorly in front of the chest. Figures 2.5a and b. Scapula. The scapula is a thin bone placed on the posterior lateral aspect of the thoracic cage. The scapula has two surfaces, three borders, three angles, and three processes. Figure 2.6. Site determination. Number 1. The lateral or glenoid angle is large and bears the glenoid cavity. Number 2. The dorsal surface is convex and is divided by the triangular spine into the supraspinous and infraspinous fossae. The costal surface is occupied by the concave subscapular fossa to fit on the convex chest wall. Figures 2.6 and 2.7. The thickest lateral border runs from the glenoid cavity above to the inferior angle below. Features. Surfaces. Number 1. The costal surface or subscapular fossa is concave and is directed medially and forwards. It is marked by three longitudinal ridges. Another thick ridge adjoins the lateral border. This part of the bone is almost rod-like. It acts as a lever for the action of serratus anterior in overhead abduction of the arm. Number two, the dorsal surface gives attachment to the spine of the scapula, which divides the surface into a smaller supraspinous fossa and a larger infraspinous fossa. The two fossae are connected by the spinoglenoid notch, situated lateral to the root of the spine. Borders. Number one, the superior border is shortest. Near the root of the coracoid process, it presents the suprascapular notch. Number two, the lateral border is thick. At the upper end, it presents the infraglenoid tubercle. Number three, the medial border is thin. It extends from the superior angle to the inferior angle. Angles. Number one, the superior angle is covered by the trapezius. Number two, the inferior angle is covered by the latissimus dorsi. It moves forwards round the chest when the arm is abducted. Number three, the lateral or glenoid angle is broad and bears the glenoid cavity or fossa, which is directed forwards, laterally, and slightly upwards. Figure 2.7. A supraglenoid tubercle is present above the glenoid cavity. Processes. Number one, the spine or spinous process is a triangular plate of bone with three borders and two surfaces. It divides the dorsal surface of the scapula into the supraspinous and infraspinous fossae. Its posterior border is called the crest of the spine. The crest has upper and lower lips. Number two, the acromion process has two borders, medial and lateral, two surfaces, superior and inferior, and a facet for the clavicle, figure 2.7. Third, the coracoid, Greek like a crow's beak, process is directed forwards and slightly laterally. It is bent and finger-like. It is an atavistic type of epiphysis. Attachments. Number one, the multipennate subscapularis muscle arises from the medial two-thirds of the subscapular fossa. Number two, the supraspinatus arises from the medial two-thirds of the supraspinous fossa, including the upper surface of the spine. Number three, the infraspinatus arises from the medial two-thirds of the infraspinous fossa, including the lower surface of the spine. Number four, the deltoid arises from the lower border of the crest of the spine and from the lateral border of the acromion. The acromial fibers are multipennate. The trapezius is inserted into the upper border of the crest of the spine and into the medial border of the acromion process. Number six, the serratus anterior is inserted along the medial border of the costal surface, one digitation from the superior angle to the root of spine, two digitations to the medial border, and five digitations to the inferior angle. Figure 2.8. Seventh, the long head of the biceps brachii arises from the supraglenoid tubercle and the short head from the lateral part of the tip of the coracoid process. Number 8. The coracobrachialis arises from the medial part of the tip of the coracoid process. Ninth, the pectoralis minor is inserted into the medial border and superior surface of the coracoid process. Figure 2.8. Number 10. The long head of the triceps brachii arises from the infraglenoid tubercle. Number 11. The teres minor arises by two slips from the upper two-thirds of the rough strip on the dorsal surface along the lateral border. Circumflex scapular artery lies between the two slips. No. Number 12. The teres major arises from the lower one-third of the rough strip on the dorsal aspect of the lateral border. Latissimus dorsi arises from the inferior angle. Number 13. The levator scapulae is inserted along the dorsal aspect of the medial border from the superior angle up to the root of the spine. Number 14th, the rhomboid minor is inserted into the medial border or dorsal aspect opposite the root of the spine. Number 15th, the rhomboid major is inserted into the medial border between the root of the spine and the inferior angle. Number 16th, the inferior belly of the omohyoid arises from the upper border near the suprascapular notch. Number 17th, the margin of the glenoid cavity gives attachment to the capsule of the shoulder joint and to the glenoidal labrum. Number 18th, the margin of the facet on the medial aspect of the acromion process gives attachment to the capsule of the acromioclavicular joint. Number 19th, the coracoacromial ligament is attached to the lateral border of the coracoid process and to the medial side of the tip of the acromion process. Number 20th, the coracohumeral ligament is attached to the root of the coracoid process. 21st, the coracoclavicular ligament is attached to the coracoid process, the trapezoid part on the superior aspect and the conoid part near the root. 22nd, the transverse ligament bridges across the suprascapular notch and converts it into a foramen which transmits the suprascapular nerve. The suprascapular vessels lie above the ligament. Figure 2.10. 23rd, the spinoglenoid ligament may bridge the spinoglenoid notch. The suprascapular vessels and nerve pass deep to it. Figure 10.3. Ossification. The scapula ossifies from one primary center and 7 secondary centers. The primary center appears near the glenoid cavity during the 8th week of development. The first secondary center appears in the middle of the coracoid process during the first year and fuses by the 15th year. The subcoracoid center appears in the root of the coracoid process during the 10th year and fuses by the 16th to 18th years. Figure 2.11. The other centers, including 2 for the acromion process, 1 for the lower 2/3 of the margin of the glenoid cavity, 1 for the medial border, and 1 for the inferior angle, appear at puberty and fuse by the 25th year. The fact of practical importance is concerned with the acromion process. If the two centers appearing for acromion process fail to unite, it may be interpreted as a fracture on radiological examination. In such cases, a radiograph of the opposite acromion process will mostly reveal similar failure of union. Clinical anatomy. Paralysis of the serratus anterior causes winging of the scapula. The medial border of the bone becomes unduly prominent and the arm cannot be abducted beyond 90 degrees. Figure 2.11. The scaphoid scapula is a developmental anomaly in which the medial border is concave. Humerus. The humerus is the bone of the arm. It is the longest bone of the upper limb. It has an upper rounded end, a lower flattened end, and a shaft. Figures 2.13 and 2.14. Side determination. Number 1. The upper end is rounded to form the head. The lower end is expanded from side to side and flattened from before backwards. Number 2. The head is directed medially, upwards, and backwards. Number 3. The lesser tubercle projects from the front of the upper end and is limited laterally by the intertubercular sulcus or bicipital groove. Features. Upper end. Number 1. The head is directed medially backwards and upwards. It articulates with the glenoid cavity of the scapula to form the shoulder joint. The head forms about 1/3 of a sphere and is much larger than the glenoid cavity. Number 2. The line separating the head from the rest of the upper end is called the anatomical neck. Number 3. The lesser tubercle is an elevation on the interior aspect of the upper end. Figure 2.13a. Number 4. The greater tubercle is an elevation that forms the lateral part of the upper end. Its upper and posterior aspect is marked by 3 impressions: upper, middle, and lower. Number 5. The intertubercular sulcus or bicipital groove separates the lesser tubercle medially from the anterior part of the greater tubercle. The sulcus has medial and lateral lips that represent downward prolongations of the lesser and greater tubercles. The narrow line separating the upper end of the humerus from the shaft is called the surgical neck. Number 7. Morphological neck lies 0.5 centimeter below surgical neck. It shows the position of epiphyseal line, figure 2.13b. Shaft. The shaft is rounded in the upper half and triangular in the lower half. It has 3 borders and 3 surfaces. Borders. Number 1. The upper one-third of the anterior border forms the lateral lip of the intertubercular sulcus. In its middle part, it forms the anterior margin of the deltoid tuberosity. The lower half of the anterior border is smooth and rounded. Number 2. The lateral border is prominent only at the lower end where it forms the lateral supracondylar ridge. In the upper part, it is barely traceable up to the posterior surface of the greater tubercle. In the middle part, it is interrupted by the radial or spiral groove. Third, the upper part of the medial border forms the medial lip of the intertubercular sulcus. About its middle, it presents a rough strip. It is continuous below with the medial supracondylar ridge. Surfaces. Number 1. The anterior lateral surface lies between the anterior and lateral borders. The upper half of this surface is covered by the deltoid. A little above the middle, it is marked by a V-shaped deltoid tuberosity. Behind the deltoid tuberosity, the radial groove runs downwards and forwards across the surface. Number 2. The anterior medial surface lies between the anterior and medial borders. Its upper one-third is narrow and forms the floor of the intertubercular sulcus. A nutrient foramen is seen near the medial border below its middle part. Figure 2.13a. Number 3. The posterior surface lies between the medial and lateral borders. Its upper part is marked by an oblique ridge. The middle one-third is crossed by the radial groove. Figure 2.13b. Lower end. The lower end of the humerus forms the condyle which is expanded from side to side and has articular and non-articular parts. The articular part includes the following. Number 1. The capitulum is a rounded projection which articulates with the head of the radius. Number 2. The trochlea is a pulley-shaped surface. It articulates with the trochlear notch of the ulna. The medial edge of the trochlea projects down 6 mm more than the lateral edge. This results in the formation of the carrying angle. See figure 10.14. The non-articular part includes the following. Number 1. The medial epicondyle is a prominent bony projection on the medial side of the lower end. It is subcutaneous and is easily felt on the medial side of the elbow. Figure 2.13a. Number 2. The lateral epicondyle is smaller than the medial epicondyle. Its anterior lateral part has a muscular impression. Number 3. The sharp lateral margin just above the lower end is called the lateral supracondylar ridge. Number 4. The medial supracondylar ridge is a similar ridge on the medial side. Number 5. The coronoid fossa is a depression just above the interior aspect of the trochlea. It accommodates the coronoid process of the ulna when the elbow is flexed. Number 6. The radial fossa is a depression present just above the interior aspect of the capitulum. It accommodates the head of the radius when the elbow is flexed. Number 7. The olecranon fossa lies just above the posterior aspect of the trochlea. It accommodates the olecranon process of the ulna when the elbow is extended. Figure 2.13b. Attachments. Number 1. The multipennate subscapularis is inserted into the lesser tubercle. Number 2. The supraspinatus is inserted into the uppermost impression on the greater tubercle. Number 3. The infraspinatus is inserted into the middle impression on the greater tubercle. Number 4. The teres minor is inserted into the lower impression on the greater tubercle. Number 5. The pectoralis major is inserted into the lateral lip of the intertubercular sulcus. The insertion is bilaminar. Number 6. The latissimus dorsi is inserted into the floor of the intertubercular sulcus. Number 7. The teres major is inserted into the middle lip or the medial lip of the intertubercular sulcus. Number 8. The contents of the intertubercular sulcus are the tendon of the long head of the biceps brachii and its synovial sheath, the ascending branch of the anterior circumflex humeral artery. Number 9. The deltoid is inserted into the deltoid tuberosity. Number 10. The coracobrachialis is inserted into the rough area on the middle of the medial border. Number 11. The brachialis arises from the lower halves of the anterior medial and the anterior lateral surfaces of the shaft. Part of the area extends onto the posterior aspect, figures 2.14a and b. Yes, number 12. The brachioradialis arises from the upper two-thirds of the lateral supracondylar ridge. Number 13. The extensor carpi radialis longus arises from the lower one-third of the lateral supracondylar ridge. Number 14. The pronator teres, humeral head, arises from the lower one-third of the medial supracondylar ridge. Number 15. The superficial flexor muscles of the forearm arise by a common origin from the interior aspect of the medial epicondyle. This is called the common flexor origin. Number 16. The superficial extensor muscles of the forearm and supinator have a common origin from the lateral epicondyle. This is called the common extensor origin. Number 17. The anconeus, Greek elbow, arises from the posterior surface of the lateral epicondyle. Number 18. Lateral head of the triceps brachii arises from oblique ridge on the upper surface or part of the posterior surface above the radial groove, while its medial head arises from posterior surface below the radial groove. Number 19. The capsular ligament of the shoulder joint is attached to the anatomical neck except on the medial side, where the line of attachment dips down by about 2 centimeters to include a small area of the shaft within the joint cavity. The line is interrupted at the intertubercular sulcus to provide an aperture through which the tendon of the long head of the biceps brachii leaves the joint cavity. Number 20. The capsular ligament of the elbow joint is attached to the lower end along a line that reaches the upper limits of the radial and coronoid fossae anteriorly and of the olecranon fossa posteriorly, so that these fossae lie within the joint cavity. Medially, the line of attachment passes between the medial epicondyle and the trochlea. On the lateral side, it passes between the lateral epicondyle and the capitulum. 21st. 3 nerves are directly related to the humerus and are therefore liable to injury. The axillary nerve at the surgical neck, the radial nerve at the radial groove, and the ulnar nerve behind the medial epicondyle. Ossification. The humerus ossifies from one primary center and 7 secondary centers. The primary center appears in the middle of the diaphysis during the 8th week of development. The upper end ossifies from 3 secondary centers, one for the head first year and one for the greater tubercle and one for the lesser tubercle. The 3 centers fuse together during the 6th year to form one compound epiphysis, which fuses with the shaft during the 20th year. The epiphyseal line encircles the bone at the level of the lowest margin of the head. This is the growing end of the bone. Remember that the nutrient foramen is always directed away from the growing end. The lower end ossifies from four centers which form two epiphyses. The centers include one for the capitulum and the lateral flange of the trochlea, one for the medial flange of the trochlea, and one for the lateral epicondyle. All three fuse during the 14th year to form another compound epiphysis which fuse with the shaft at about 16 years. The center for the medial epicondyle appears during 4 to 6 years, forms a separate epiphysis, and fuses with the shaft during the 20th year. Clinical anatomy. The common sites of fracture of humerus are the surgical neck, shaft, and supracondylar region. Supracondylar fracture is common in young age. It is produced by a fall on the outstretched hand. The lower fragment is mostly displaced backward so that the elbow is unduly prominent, as in dislocation of the elbow joint. This fracture may cause injury to the elbow joint, or it may cause injury to the median nerve also. It may also lead to Volkmann's ischemic contracture caused by the occlusion of the brachial artery. The three bony points of a normal elbow form the equilateral triangle in a flexed elbow and are in one line in an extended elbow. The humerus has a poor blood supply at the junction of its upper one-third and lower two-thirds. Fractures at this site show delayed union or non-union. The head of the humerus commonly dislocates inferiorly subglenular, figure 2.18. So this was part 1 of chapter 2.